Good afternoon. My name is Jessica Perlow, and I am the ABIM Foundation's Executive Vice President. Thank you for joining us for our February Trust Conversations webinar a couple of months later. This is a core element of our Foundation's Building Trust initiative. Before we begin, I'd like to review a few logistics with you. This meeting will be recorded and shared, and while our presenters are speaking, we will have your lines muted to reduce unnecessary background noise. There will be a chance at the end of our hour for our speakers to answer any questions that you might have, and we encourage you to enter questions into the chat throughout the conversation. Today, this is the second conversation that we're having in recent months devoted to this trust conversation on the topic of medical debt. The Foundation is interested in this topic because we believe that a world in which more than 100 million Americans are in medical debt is one in which it's exceedingly difficult to achieve our goal of helping build trust. Rather, the status quo is breeding distrust, and it's eroding relationships between patients and systems and the clinicians who are providing their care. We're using our convening power, which we've brought to bear on issues such as medical misinformation and inequity, to highlight approaches to addressing this debt crisis. Today, we are joined by Dr. Luke Messick, who's an emergency medicine physician at Brigham and Women's Hospital and a historian of health policy in the United States and Africa. He's the author of Your Money or Your Life, Debt Collection in American Medicine, which covers the history of medical debt in the US. Jackie Judd will be moderating today's conversation. Jackie spent decades in journalism reporting for ABC News, CBS News, NPR, PBS NewsHour, and the Kaiser Family Foundation. Jackie serves as a member of the board of directors of the Josiah Macy Foundation. She's the immediate past chair of the ABIM Foundation Board of Trustees. And we're very grateful she's here with us today. Thank you for joining us for what I know will be a great conversation. And I'll turn it over to Jackie.
Thank you, Jess. Good afternoon, everybody, and thank you for joining us. Luke, there you are. Thank you, especially for being here with us. So it's not an obvious line to go from emergency room doctor, which you continue to be, to historian of medical debt in America. Your entry into the world started when you walked into the county courthouse in Warwick, Rhode Island. Tell us what took you there and what was the shock that awaited you?
Yeah, thanks, Jackie. And thanks so much, everyone, for coming. I'm really excited for the conversation. I came to this issue, I think, honestly, I was interested in it because I started hearing some talk from friends of mine in other hospitals at Johns Hopkins, other places around the country that were protesting their own institutions for suing patients with medical debt, taking them to court. And I was working in Rhode Island at the time, and I was in residency. I didn't think that my own hospital was involved in this, but I really just wanted to make sure. It was the kind of thing where I kept thinking, it was a nagging thought when I was going to bed at night, being like, I just want to make sure that this isn't something that's going on at my institution. I didn't think it was. I hadn't heard about it, but I did want to try and make sure. So I went down to the county courthouse, a place I'd never been before, actually a prettier building than my hospital, and started looking at the court records. I just asked to be let into the records, and they put me in the back in this small room with an old computer, and you could type in whatever institution you wanted, whatever person you wanted, and look and see if they'd been a defendant or plaintiff in any lawsuits. And when I typed in my own hospital, first I saw some lawsuits related to medical malpractice, which is usually what doctors think of when they think of lawsuits. But then I looked a little further and I saw that a lot of the times the defendant was the patient and the plaintiff was the hospital. And I was trying to figure out why, and then I started looking, and those were the cases I was worried about. Hundreds of cases where my own hospital had been suing patients. And I looked further and started to see their responses to the subpoenas or to the notifications that they were being sued. And they were really plaintive letters back saying things like, I'm a single mom on I'm an elderly person on a fixed income. I am a recent immigrant. I'm living on disability. People really in dire straits already who were writing, asking for some degree of lenience from the hospital. And they would get some, but really only in the form of a payment plan. They would be asked to or demanded to pay back a single visit to the hospital for the next 6-7 years. And if they didn't pay, they would be paying double-digit interest. And if they didn't pay that, then they'd have their wages garnished and all sorts of other punitive measures placed on them. So that was my realization that my own hospital was involved in this problem.
And you were shocked by it.
I was
How
shocked.
did,
Yeah.
how did you feel the next day when you walked back into the emergency room to work in an institution that you now had a better understanding of?
Yeah, I gotta say it was with some degree of shame. I had always tried to counsel my patients because cost did come up.
Sure.
People would ask, how much is this going to cost, this x-ray, this overnight stay? I would always tell them I didn't know because I didn't. And I would then say, but whatever it is, our job is just to look after your best interest. Your best medical interest is that you stay for this test. And sometimes people wouldn't. They wouldn't trust that what I said was the case. But I thought I had their best interests at heart. But I realized that the more I tried to assuage their concerns, the more I would seem kind of part of the con later when they received a notification that they were being sued by the hospital for a bill that they couldn't afford to pay.
And
so
all of this, your visit to the courthouse took place, of course, several years ago. To this day, is there a particular patient whose experience has stayed with you?
Yeah, absolutely. There are a few, but there's one in particular, and I talk about her in the book, and I don't give identifying details, but she'd come in with a complaint of a mass, which was a little strange because usually people don't come in with masses. They go see their doctor for them early in the process and try to figure out if it was some sort of malignant growth. But in her case, she was coming in with a mass, she said, and I went to her room to see what was going on, and she had a huge, very painful fungating mass on her body. The kinds of things I'd seen in Rwanda, but had never seen in the United States. I'd never seen it before. And it was, she told me, terribly painful.
Mm-hmm.
I asked her why she had waited so long to come. She said she'd noticed it months before, 6 months before. And she said that she was worried that she would leave her family in mountains of debt if she sought care for what she knew was cancer. And she wasn't wrong. The more research I did, the more I would find out that financial toxicity for oncologic care is a huge and massive problem, one that we know leads people to shorter lives and to mistreatments. But in her case, she knew that. She'd worked in healthcare her whole life.
Oh.
And she decided that for her, it wasn't worth it. And she had only come in at that point looking for morphine, looking for palliation, because it just gotten so painful. So that experience really did stick with me when I realized what we were doing to people. People who knew better were staying away.
Yeah. And so what emerged from the experiences you just shared is this deeply researched book tracing the history of medical debt in the United States. I mean, going back to when chickens were bartered for healthcare. I don't want to start that far back, Luke, but what seems most relevant for this conversation and for where we are today is what happens in the 1960s going forward. Spend a few minutes sharing the 3 or 4 events that in the moment may have seemed right, but looking back, of course, you could see it's contributed to where we are now with medical debt.
Absolutely. And some of this history is familiar, but
Yeah.
when you look at it through the lens of medical debt, it starts looking a little different.
Yeah.
So in the 60s, you're right, there's huge changes. And one is the passage of Medicare and Medicaid. In 1965, under President Johnson, you have this massive decrease in the number of uninsured people, especially elderly Americans. And that made a big difference for folks. But what it also did was it led hospitals to argue to the federal government, to the IRS, that the standard to which they were being held to maintain their nonprofit and therefore tax-exempt status was no longer necessary. This charity care standard that had been promulgated in the 50s, stating that hospitals had to provide charity care to the extent of their financial ability, that was the wording, to the extent of their financial ability, wasn't really adequate, wasn't necessary anymore, because who even needed charity care, right? There's Medicaid for the poor, there's Medicare for the elderly. Like, who are all these people who are going to need charity care anymore? And so the standard should be changed. And so their argument was accepted by a young staff attorney who worked at the IRS, who then wrote and changed the standard to what we now have, the community benefit standard. It's been changed over the years since, but what he wrote in the late 60s in a change that he did without public comment has stood the test of time, not because it works, but because it's been so popular with the AHA, for whom he eventually worked as their chief counsel. So this is the standard that basically says that hospitals can justify their nonprofit status with all manner of activities, including training residents, including research, other forms of community activities, and charity care doesn't necessarily have to be a part of it. So that was a huge change in the ways that hospitals see their own responsibility towards poor patients. And as we know, there's still a lot of patients who can't afford their care, even with Medicare and Medicaid. So that was one change. The second, I think, is important to note that in the 1980s, you have a huge change in the way that Medicare and Medicaid start reimbursing hospitals. As a result of changes in federal law, spurred by vast increases in federal spending and concerns about overspending on healthcare, you have changes in the ways that hospitals are reimbursed, so that for many hospitals, the cost of providing care to a Medicare and especially a Medicaid patient wasn't matched by the reimbursement they were receiving. For a while, they were able to make up the difference with privately insured patients, and we still see this in the quest for the right payer mix, right? Hospitals seeking to get those lucrative privately insured patients. But at the time, they were able to make up that difference for a little while. But then with HMOs and with the push towards lower reimbursements for even privately insured patients, it became much more difficult for hospitals to stay afloat, especially if they had publicly insured patients or a large number of uninsured patients. And so that pushed a lot of hospitals to seek ways to collect from patients who were self-pay or uninsured patients, or maybe uninsured patients. And one of the ways they did that was to listen to that siren song from third-party debt collectors. These are folks who would approach a hospital at a conference or over dinner or whatever and say, you know, it's really not your forte to collect debts from patients. You guys deal with insurance companies, we know that, but you don't want to deal with patients. No one in your offices wants to call individual patients and tell them to pay up. We'll do that. We're debt collectors. That's what we do. So sell us your debt for pennies on the dollar, or assign us your debt for a period of time and pay us a commission on whatever we collect. And you won't even have to worry about that anymore. And so that was the era where you see the rise of the third-party debt collector, which I go into in great detail in the book, because I think that did lead to much more aggressive debt collection tactics. Whereas in the early part of the 20th century and even the mid-century, hospitals were keeping these debts on their books for years, even decades. They weren't pursuing them that aggressively. By the late part of the 20th century, you have patients being taken to court. You have patients having their wages garnished. You have patients having their homes foreclosed on by hospitals using these third parties. So that really changed things a lot. And the last one, briefly, is the rise of the high deductible health insurance plan, which we're still living with today, which was promoted by the Medicare Modernization Act of 2003 and by Obamacare by the ACA in 2010. So that those changes led to the rise of medical debt among the insured. We have more insured people, but we have a lot of what we should consider underinsured, because they're, even with that level of insurance, the copays and deductibles are so high that medical debts are a huge burden for folks who fall into the category of insured patients. So we have things that in some senses are great changes, right? The rise of Medicare, Medicaid, ACA, Medicaid expansion, those drastically decreased the number of uninsured patients, but they also had these weird side effects where the problems of debt and the lack of charity care or financial assistance became kind of a byproduct of those changes.
Let's just pause for a moment here and let me ask you, in the newspaper business, it would be called the nut graph. Give us some statistics on how much medical debt is out there, how many patients, former patients, are impacted in a material way by it.
Yeah. You guys had some great talks by Noam Levy and other folks who have documented this in great detail. But most recent statistics say that about 100 million Americans owe debt to a medical or dental provider. That's 1 in 3 Americans. The amount of debt is difficult to tally because some of it is placed on credit cards, some of it is owed to friends and family. If you just look at the debts that were placed on credit reports, tally that's more difficult to do now that not all debts are being reported to credit bureaus, but it was at least 80 billion a couple of years ago, but other estimates place it closer to 200 billion, so it's hard to say. This is a problem that affects a huge swath of Americans, but as you might expect, it doesn't affect all Americans equally. It follows along lines of race, class, gender in ways you would totally expect. Black and Hispanic Americans are affected more than white Americans. Women are affected more than men, and low-income Americans are affected more than upper-income Americans. But it's a massive problem that really does just cut across.
One of the recurring themes in the book, Luke, is the depersonalization of the healthcare system, and that, I would say, very much includes the growth of the debt collection industry, which has furthered that. But your point is that with this depersonalization, instead of Jackie Judd seeking healthcare, patient 321 is seeking healthcare, and then it becomes easier to send a debt collector after 321. So share some of your findings about what the impact of that has been and some patient examples.
Yeah, absolutely. I think one thing, to not to go back too far in history, but it is important to note that, until fairly recently, most physicians were private practice physicians, and they weren't employed by large entities like hospitals or health insurance companies or private equity companies the way we are now, the way I am now, employed by a large hospital system. So that was important because if you were a doctor seeking to collect debts, it was your job to collect that debt. You had to approach the patient and say what you were going to pay, whether you're going to sever the relationship, whether you're going to put them on a payment plan, whether you're going to forgive the debt entirely. So that was a deeply personal and often very fraught relationship. And I won't say those were perfect days in any way. A lot of doctors wrote to medical journals. A lot of the first chapter is basically doctors writing to medical journals worried about their own debts, about dying in debt because their patients wouldn't pay them. Couldn't pay them, wouldn't pay them. It was hard to tell. So that was a big issue in the 19th century, early 20th century. Hospitals had this issue too, but a lot of them were built around the idea of taking care of patients who didn't have anyone else to care for them. Most hospitals arose from the almshouse tradition or were built by ethnic associations or by religious institutions. So these were places that were explicitly devoted to charity care. That all changed in the 20th century. Hospitals and physicians, private practice physicians, changed drastically. And so we don't live in that era anymore. And like you said, things have become vastly depersonalized. And so instead of a doctor approaching a patient for debt, or even a hospital writing to a patient about debt, it's oftentimes a third-party collector who might have bought and sold this debt on the secondary market. It might be bought and sold multiple times to the point where the person contacting you over the phone really has no role in patient care, no connection to you as a patient. You are a number on a sheet. You are a number on a spreadsheet that they are trying to collect the maximum amount out of. And that definitely changes the relationship. If you're no longer making a personal plea to your doctor, but instead having an argument with someone who has no social role in your life other than as a debt collector, that's going to change the dynamic entirely. It doesn't mean that they're not going to blame their doctor for what's happening to them, but the person on the end of the phone has no recourse to the doctor. Like they're not going to call the doctor and ask them permission to forgive the debt. It's become a completely depersonalized relationship where those social bonds between doctor and patient no longer hold.
So this begs the question, though, in 2024, what is the role and the responsibility of a clinician, if any, in terms of having some knowledge about what the test you're recommending will cost and what guidance should or could be given to a patient about managing that cost? I know you said earlier, and you've written in the book, a patient asked you and you had no idea, which I presume is pretty typical.
Yeah. Yeah. And this is tough, right? I don't want to sit here and say that it's doctor's fault, it's nurse's fault, and it's our job to fix it. Especially during and after COVID, like lots of responsibilities have been placed on our doorstep, maybe too many. And to lay one more and say that this new social ill, this other social ill is also our fault and our responsibility to fix is maybe one demand too many for an overburdened workforce. But I do think it is incumbent on us, especially those of us who work for these large institutions, to know what they're doing, to know what we are involved in. Like, we can't wash our hands of it entirely. I take heart from the work of folks who've gone before us. Like at Hopkins, it was the nursing unions who really pushed hard to make sure that Johns Hopkins Hospital was no longer suing so many of their patients and garnishing their wages. Oftentimes, it was the hospital employees themselves as patients who were being sued. So, that was some personal knowledge that was driving it as well. At Yale in the early 2000s, there were a series of articles written by the Wall Street Journal as an expose to show that they were placing liens on homes and foreclosing on homes of vast swaths of the Yale, of the New Haven community, oftentimes the lowest income folks in New Haven. But the folks who actually started that movement to get Yale New Haven to stop those practices, they were food service workers. They were the cafeteria workers at the hospital, many of whom were being sued themselves. So, I think we can take heart from some other folks who work in our hospitals and follow their example in really pushing our institutions to do better. And so a lot of them have, like in the last few years, I think in part as a result of the pandemic, a lot of hospitals have stopped pursuing the most aggressive debt collection measures. You see fewer lawsuits against patients in studies that have been done in Wisconsin and Maryland. You see fewer patients being taken to court. You see some states passing legislation to do the work for us, actually, to change the laws in ways that don't allow physicians and hospitals to take the most aggressive measures.
And I want to get more in depth on that, but just to button up the conversation about a clinician's responsibility, I don't think you address this in your book, but given the amount of research you've done, do you think that doctors' salaries are part of the problem?
No, I see why you'd say that. I mean, doctors are generally well paid, and we do live comfortable lives after repaying our own debts. But I don't think the doctors' salaries are the problem here. I mean, I do think that the rapid growth of large institutions in healthcare that have rendered physicians and healthcare providers more generally more distant from patients, from the patient experience. I think that is an important part of it. But I don't think that the fact that we're getting paid by Medicare, Medicaid, and private insurers is the problem. In fact, one of the things that's so fascinating about this problem is that medical debts held by individual patients, even if they were pursued to the utmost, even if every patient was taken to court, that wouldn't help the hospital's bottom line. There's a great study by Marty Makary at Johns Hopkins, who studied lawsuits in Virginia and found that the hospitals who pursued patients the most aggressively, they made from those tactics about 0.1% of their revenue. or 0.2% in the very, very highest cases. Like, these aren't tactics that are helping hospitals stay open, even if they're in dire financial straits. So we could do away with them entirely, and it wouldn't make any difference for whether a hospital's hard up, whether a hospital's doing well, whether they can pay their doctors or not. So, I do think doctors have a special responsibility to do something about this, given that we are generally living more comfortably than even other people working in our institutions. I think that hospital administrators have a huge responsibility to do something about this, given that it is their job to look after the patients in their institution. But I also am cognizant of the fact that asking doctors to take care of patients in front of them is a huge enough responsibility, and I don't think it can be just our responsibility.
Yeah. So you've already anticipated my next question, which is, who really does come to the rescue here? And I feel almost naive asking this question, but should healthcare systems be trying to solve this problem in a way that actually reflects internal but publicly stated values?
Yeah, absolutely. I mean, healthcare systems have their own challenges, right? Some of them are struggling to stay afloat. Some of them are safety net institutions that struggle every day, and every year every year hospitals close because they can't get adequate revenue. So getting states to adequately reimburse on Medicare and Medicaid patients, and disproportionate share payments, and every other thing that hospitals need if they're taking care of low-income patients to stay afloat is super important. But I do think that there are some great examples of hospitals that have done good work in this area. I was looking for these examples around the country. I said, it can't be the case that every hospital is suing patients, and it's not the case. Some have forsworn it entirely. And it has to be the case that some hospitals are just making it easier for patients than others, right? There are some hospitals that make it extremely difficult to apply for charity care financial assistance. They don't tell patients that it's available, and they make the application process very onerous. But there are also hospitals that make it very easy. Oregon Health and Sciences University in Portland, Oregon is probably the best example that I've found so far. They, at the point of care, when someone comes in and they find out that the patient is uninsured or expresses any concern about paying their bill, they're approached by someone from the revenue office, and they say, if you just tell us, if you're willing, and you tell us your name and social security number, we'll run you through the system that we have set up to estimate your annual income. They use a proprietary software, but from a credit agency that's available to any hospital. And they can estimate their income and say, you're very likely to make under our cutoff for free or discounted care. Most hospitals, at most nonprofit hospitals, about 200% of the federal poverty level to get free care entirely. So that's like $60,000 for a family of 4, and about twice that much for any discounted care. If they find out you're likely to be under that income level, without an application, they say, you know what, forget it. Don't even apply. You're going to get free care here, right? I think that's amazing. I think that's exactly what we should be doing. We should not be burdening our patients with onerous application processes that are not necessary. So I do think that hospital systems can, and in some cases do the work to make this much better for patients.
And the example you just cited clearly is an exception. What is the more typical experience of a patient who goes to the hospital and then can't pay the bill?
Yeah.
In terms of understanding what he or she may be eligible for.
Yeah. You may get a notification, say if you're laid in a gurney in the emergency department, that someone will roll around on a computer and register you in the midst of your intake, and they'll ask for your insurance information. They'll hand you some pieces of paper stating the hospital's policy, including its financial assistance policy, which is also available on its website, although sometimes difficult to find. You'll leave the emergency department hoping that if you are insured, the insurance will cover it. Maybe you'll find out a few months later that it didn't cover what you hoped it would. Or if you're uninsured, of course, it hadn't covered anything at all. You'll start getting bills. If you don't pay those right away, you'll start getting more letters and calls. And then eventually, a few months later, the hospital can start farming it out to a third-party agency, or they can start themselves taking what are called extraordinary collections actions. And so I think it's important to understand what are these things that hospitals can do. So very briefly, they can report you to a credit bureau, although that's starting to change. Credit bureaus voluntarily stopped reporting certain debts related to medical providers. And the
Yeah.
Biden administration is trying to eliminate it entirely.
Yeah.
They can take you to court, so sue you if you lose that lawsuit, which patients almost always do. They can garnish your wages, they can put a lien on your home, they can foreclose on your home. If you don't show up for those hearings, you can be placed in jail. So there's something called a body attachment. So people can be, you can have a warrant for your arrest and you can be placed in jail. And people have been placed in jail, sometimes committing suicide thereafter, if they don't report for these hearings related to medical debt. So this is like the modern age of debtor prison. So things can get really dark really fast. It doesn't always happen. Not every hospital is going to do this to you, but this is the kind of thing that is lurking in the back of some of our patients' minds if they know what's going on, if they can't pay that $2,000 facility fee or other crazy bills that they might receive at the end of their visits.
Yeah. Luke, a couple months ago, you and a colleague wrote an op-ed piece that was in the Washington Post. And it was to acknowledge, one, this more recent trend, I would say, of municipalities, nonprofits, et cetera, scooping up, buying debt, and then just essentially forgiving it. But you and your writing partner went on to write about some other suggested, seemingly achievable changes. You weren't talking about, blowing up the payment system in our healthcare system, but achievable things like making it easier for a patient when they enter into a hospital to find out what their eligibility is. What are some of the other ideas that you have for that?
Yeah, absolutely. So my writing partner was Astra Taylor, who is an incredible writer, documentarian, filmmaker, who herself led the movement. She led some of the most important movements of this last decade, including the movement to cancel student debt, but also movements to buy and forgive medical debt. They did this in the aftermath of Occupy Wall Street, when they found out a lot of people were complaining about medical, or were living with medical debt. And they started this movement to buy and forgive medical debt. But what we realized, and what she quickly realized, was that this was never going to be nearly enough. And more concerningly,
didn't get to the root problem.
Yeah, and it also risks kind of rewarding the worst actors. You're paying for the debts of hospitals that maybe should have forgiven those debts, or third-party collectors who, were pursuing patients aggressively. So it's not necessarily helping the folks who need help the most, in terms of the actual healthcare providers, to say nothing of patients. So yeah, it's not nearly enough, and we need to do more. And the things that we can do are what we discussed. So presumptive eligibility, making sure that you tell patients at the point of care whether they're eligible for financial assistance, without making them go through months-long onerous processes, asking them to call your office 5 times to make sure they know if they're eligible or not. We can also make sure that our state regulators our state legislators are passing legislation that outlaws the worst practices. We don't need to have patients being taken to court over medical debt or thrown in jail for medical debt. That's just not necessary in any way, and it's definitely eroding trust between providers and patients. And then there's much more we can do to make sure that we're paying providers appropriately. If they're taking care of Medicare and Medicaid patients, then they should be paid for the costs that they incur. And for many hospitals, the reimbursements are just not adequate to make up for those costs. So, if our hospitals are predominantly taking care of Medicaid patients, they shouldn't be induced to, try to move to a more remunerative area with richer patients. We should just make sure that hospitals and healthcare providers can take care of the patients in their area. So that's a larger scale change. Some of it really is very achievable in the immediate term. A hospital could change its financial assistance practices tomorrow. Some of it would take much more. And we eventually go to talking about single payer healthcare, which I do think is the ultimate solution. But in the interim, there are so many things that we can do to make things a lot better.
Do you think that this recent move to not allow, not all medical debt, but some medical debt to not be included in credit reports, is that nibbling around the edges, or does that have a material impact on people who carry debt?
It definitely has a material impact. I mean, these by placing debts on credit reports, you're hurting a patient's ability to get a mortgage, to get a job sometimes to get a security clearance. Sometimes it's these things can be very important for patients in their financial lives and the rest of their lives. And some of the things that were going on, I write them in the book. Some of the things that were going on with patients were just so you can see why they would erode trust, because they seem so petty. One practice that was going on a lot before these changes took place was if a patient had a debt to a hospital, even a very small one, like $15, like a copay they didn't pay, then that debt would be parked on their credit report before they were even informed about it. Right? Debt collectors had the practice of doing this. In fact, there was one that was run by a member of Congress in Corning, New York, who would do this for patients in his area. And so everyone who went to the hospital in Corning and didn't pay their copay because they forgot about it, were realizing that their credit scores were going down, and they started calling up the debt collector and saying, "What's going on? Why is this happening? Why is my debt on the credit report? You didn't even tell me about it." And they say, "Well, would you like to pay it now?" Right? It's a way to prevent you from having to do any outreach. So stuff like that can't happen anymore, which is a good outcome. But we certainly have to do more. But that was a good outcome.
You've mentioned a few times throughout our conversation about the erosion of debt, or the erosion of trust, rather, because of what's happening with medical debt. And the connection is obvious. We don't even need to talk about that. What I'm more interested in hearing is instances where you, in your capacity as a clinician, as an ER doc, have experienced that erosion of trust. Hard to pin it down specifically maybe to debt, but what's the impact in the day in, day out life of someone who practices medicine?
Yeah. The emergency department is a very high stakes, high pressure situation. People are having probably the worst days of their lives when they come in. And it's our job to try to figure out if there's something horrific going on with them. And sometimes we don't even come up with an answer, but we can say with some degree of certainty, we don't think that you're having a heart attack. We don't think you're having a stroke. We don't think the worst is happening right now. But that involves a lot of testing. That involves a lot of time. That involves a lot of invasive procedures. And we're asking patients to submit to those and to trust us that we're going to have their best interests at heart. And sometimes when I approach patients and I say, "I think you need a CAT scan. I think you need an MRI. I think you need to stay overnight," they'll say things like, "You're just trying to make a buck off me. Like, I don't need this. I came in because I had a twinge in my chest. And now you're telling me I need an EKG, a chest X-ray, a CAT scan, and an overnight stay like that. You're just trying to make a buck off me." And I try my best to, in that limited time, build rapport and explain why we're doing all these things and why it is in their best interest. But you can understand why they'd be concerned, because they might in a few months get a huge bill. And all these testing, which probably will reveal nothing if all is well, will not seem worth it at that point. So I do hear that from patients, and even if they're not going to say something like, "You're just trying to make a buck off me," you can tell the hesitancy, or the question that comes up sometimes: "How much is this going to cost? Do you know how much it'll cost? The stay will cost?" And I've gone around and I've asked literally when I was a resident, I used to go around and ask everyone in the ED I could find, the most senior physicians I could find, "Do you have any idea how much this costs?" And they said, "Of course not. Like, it depends on their insurance. It depends, depends what they get." It's not our job to know that, and we can't know that. I don't think we. Sorry.
Yeah, the trust piece is not only, of course, between a physician and a patient, but you as a physician felt broken by what you found in that county courthouse several years ago. And how did that impact your trust and faith in the people who were employing you?
Fair question. Yeah, I mean, I did write a pretty pointedly worded essay about this, and I didn't trust that they would do anything immediately about it if I approached them. So I ended up going directly to the press, which maybe was inadvisable, but I didn't trust that they would change things quickly enough. And so I ended up writing in this small, blog in Rhode Island, which I didn't think would make many waves, but I got a call immediately from my boss asking me why I was doing this. They did change their practices pretty quickly after they looked into them, and they claimed the folks at the hospital, including the CFO, claimed that she didn't know what was going on. She didn't know that their debt collection company was doing this, which I think is true. I think they didn't know. I don't think it's an excuse, but I do think we've become so distant from this practice, from what we're doing to patients, that even the CFO of the hospital can legitimately claim, maybe not, they can truthfully claim, even though she probably shouldn't be able to, she can truthfully claim that she doesn't know what's going on. So, I do think some degree of like, some degree of understanding of those roles is probably necessary. But, I got to say, especially in the last few years, there's a lot of distrust between physicians, frontline providers, and the C-suite executives in the hospital. I think this is part of it.
Well, you write that you have this beautiful line in the book that I wish I had at my fingertips, but you just alluded to it. And it's the line about how we reach this point through a combination of swashbuckling entrepreneurship, empire building, and blindness. And that's what you just described. Maybe willful blindness sometimes, but blindness. Okay. I've had enough of your time, Luke. At this point, I'm going to turn it back over to Jess, who has been fielding questions in the chat room so we can continue the conversation with our audience. Jess?
Thank you both so much. I could listen to you all day, so I almost don't want to interrupt here, but we do have a few good questions for you. Lorna is asking, are any physician groups like the AMA or specialty societies doing anything to address medical debt in terms of lobbying or concrete initiatives?
Yeah, certainly there are. The AMA has historically not been a fantastic actor on this front. I mean, they've been some of the primary actors against national health insurance for the better part of a century. So there's a movement within the student section of the AMA to change that, and they've almost been successful in getting the AMA to at least stop funding efforts to prevent something like a Medicare for All, which would, with first dollar coverage, prevent most medical debts from even being incurred in the first place. There's also other groups. I mean, I'm part of some. Physicians for a National Health Program is a group that's been pushing for national single payer for decades. But even the specialty societies, including ABEM, have made more motions and more policy statements about this in recent years that I think has been very heartening to see. Even if the AMA itself hasn't taken the lead role, I mean, many fewer physicians are members of the AMA these days than used to be the case. And most of us are members of our respective specialty societies, and some of those specialty societies have made moves to change things. But I will say that physician groups in particular have been notably absent in these discussions. Most of the work, most of the advocacy has been done by nursing organizations like National Nurses United, or like I mentioned, like food service workers in the hospital working through the SEIU. So there hasn't been nearly enough from the physicians on this.
That's a good segue to another question here from Javi. Actually, excuse me. Javi, who's asking how much of that medical debt never really needed to happen in the first place? How can physicians be more cost aware, not just when patients ask? Yeah,
I think the question about cost transparency or cost awareness comes up frequently. What if all the doctors knew exactly what everything costs and we incorporated that into our medical decision making? I know there are physicians on the call and maybe some who feel differently, but I personally don't want to change standards of care that I practice based on my patient's insurance status or my patient's ability to pay. I think that everyone should get the same standard of care. And I worry that if we know too much about how much things cost or will cost patients, even if that data can be accurately presented. I know hospitals are supposed to post costs, and some are doing it and some aren't, and some are real and some are not. That will change our practices in ways that will further disadvantage the most disadvantaged patients. So I really do worry about that, and especially in the emergency context. we don't want our patients thinking too much about cost. We don't want them shopping around, right? If you're having a heart attack and you call EMS and you say, oh, can you take me to the low-cost hospital that's 2 hours farther away? Like, that is not the right outcome. Like, time is muscle, time is brain. Like, we don't want these sorts of calculations coming in. I mean, health economists have known this forever. Kenneth Arrow wrote this in the 60s, that we shouldn't see healthcare as a free market enterprise, because it can never be. It's full of imperfect information, imperfect competition. It's just not the place where the free market can work its wonders. So I think that's important. But you're right. I don't think these medical debts have to be incurred. They don't have to exist, right? Like, sometimes when you bring up international comparisons, people start thinking you're doing something wild and crazy and hopefully idealistic. But if you look at Canada, if you look at the UK, when they passed national health insurance, it was very difficult to pass. And people who were advocating for those changes were, in the UK, likened to Nazis. In Canada, it spurred doctors to go on strike for a brief amount of time. So, these things are not easy to pass, but I do think we'd have to look pretty broadly and expand our imagination a little more if we're really going to solve this problem once and for all.
Have you looked at medical debt in the UK where they have single payer?
Oh yeah, it's almost unheard of. I mean, the amount of people going into what are called catastrophic or having catastrophic health expenditures is vastly higher in the United States than any other country in the OECD. It's about more than 2 times higher than any other country. I think second is Australia, and then most of the European countries, including the UK, are just 4 or 5 times less. So the league we should put ourselves in are countries that have patients pay at the point of care through user fees. And these are usually like low-income countries that don't have health insurance systems set up at all. So that's basically the pool we're swimming in, when we don't need to be. No country should be living like that, but certainly we don't need to at all. We pay more than anybody else.
Yeah. And this gets to a question from Daniel Pomerantz, who's asking, how much of this is the financialization of healthcare and the especially pernicious impact of private equity and other expressly for-profit entities in healthcare?
A lot of it. Yeah, I think you really hit the nail on the head. I mean, some of the entities that were pushing most against even very small steps towards a solution have been those entities. I mean, I'm a member of, or I was until I stopped paying my dues, a member of ACEP, the American College of Emergency Physicians. And that's a group that I'm ashamed to say does have a lot of private equity influence. And so as a result, when the No Surprises Act was being proposed and debated, ACEP and some of its private equity backers were some of the greatest voices against it, not for any legitimate reason that I could discern, but just because it would harm their model of basically surprise billing whenever they could possibly do it. And they were right, because when the No Surprises Act passed, some of those entities went belly up. So this is really it really is a problem of financialization. But even some of the entities that you would think would be immune to it, namely private nonprofit hospitals, which have forsworn any sorts of profits, which do not pay shareholders, which do not pay taxes because of their community benefit, they are some of the ones who are the worst actors. It's not always for-profit hospitals. It's not always private equity institutions. Sometimes it's the private nonprofit that you would think would be better.
So Ellen has a question here that I have as well. If pursuing medical debt makes so little difference to hospitals' bottom lines, then why do it?
Yeah, that's a great question. That was one of the ones that I couldn't figure out for a while. What is the point? Like, who is doing this if it's not actually keeping your hospital afloat? I've come up with a few answers. Some of them come directly from depositions where hospitals admit and state that they do not want uninsured and underinsured patients to show up, right? They're trying to maximize their payer mix. And this is an attempt by pursuing these debts aggressively to basically scare patients away. Sometimes it's explicitly stated like that. It was the New York Times writers, Jessica Silverberg Green, and I always get her last name wrong, but she was writing a story and she actually sent me this deposition, which she said I could share with people. But there are other reasons too, and I think part of it is the discussion of blindness we had. where the folks who are making the decision to, say, farm debt out to a third party, who will then pursue it aggressively, really have no connection to patient care. And so, if it's even to them, even in the C-suite, the problem is just maximizing revenues and minimizing costs, then this is going to increase your revenues, even in some small, kind of pitiful manner. And so if they're just trying to increase revenues by any means necessary, then this is just one way to do it. And who are they meeting with? They're not meeting with the low-income patients. They're meeting at their conferences, at their dinners with third-party debt collectors who are saying that they're going to take a problem off their hands. So I do think a lot of it has to do with the way we've structured our organizations. And a lot of our C-suites are filled not with physicians or nurses, but with financial executives. And I think that's part of it too.
Is any of this defensive medicine?
Maybe. I didn't get into that as much in the book. And I don't know, say, if places with like tort reform or tougher medical malpractice laws have differences in this. I don't think it's really the crux of the problem. It might drive up costs. Certainly I practice it sometimes myself. It probably does drive up costs and therefore debts for some people. But I haven't seen any great evidence that solving the defensive medicine problem will in and of itself solve this problem in any meaningful way. It'd be a good study though. I've never seen it.
All right, last question from me, and then I'm going to turn it back to Jackie and we'll close out. But how can medical professionals advocate? So we talked about understanding and cost transparency, but advocating for affordable healthcare or government-funded healthcare as a basic human right.
Yeah, amen. I mean, I think there are a lot of things we can do. One is knowing what our institutions are doing. So look up your hospital's financial assistance policy. It should be available online. You can see what the cutoffs are for free and discounted care. You can see what the application process looks like. So if a patient asks you, you can tell them. And if the hospital isn't doing enough, you can advocate for them to do more. You can tell them to stop suing patients if that's what they're doing. More and more hospitals are force wearing the practice, but I do think it can't get abolished soon enough. There are organizations out there that are doing great work, not only some of the physicians groups that I mentioned, but also private organizations, nonprofits. I'm involved in one called $4, which was started by a former bartender in Oregon who'd had problems with medical debt in his family himself, and now has made it his mission to help any patient who asks, any person who asks across the country, apply for financial assistance without asking them for a dime. And through that work, they've come up with some great data about which hospitals are making it easy, which hospitals are making it tough. We're using some of that data in some papers we're putting out about the ease or difficulty of financial assistance around the country, and how much missed financial assistance there really is out there, like billions of dollars a year in financial assistance that could be claimed but is not, because mostly it's so difficult to do. And then these larger issues of advocating for changes in state law to make medical debt less of a reality. I've been consulting with Senator Sanders' office and Representative Ro Khanna's office on the Medical Debt Cancellation Act, which they're putting out, and which could do more to eliminate medical debt from credit reports and make it easier for patients to qualify for charity care and cancel more debts. So there is great stuff happening. There's more ways to get involved than any one person could do. But we definitely need more people in this.
Thank you for this, Luke. We're going to put a link to $4 in the chat if you want to learn more about it. And back to you, Jackie.
Yeah, Luke, just as a final question, I always think in conversations like this, it's good to end thinking about the future. And as you just said, there's a lot happening out there, and certainly more than I realized. And I thank you for that very much. And yet, when you step back, the problem is, as one of my kids in their earlier years would have said, ginormous. In 5 or 10 years, do you think we all come back together and say significant progress has been made in reducing the backbreaking cost of medicine, which leads to medical debt, which crushes some people?
I choose to be hopeful about this, and I do think it will. I mean, I think that the last few years have seen really an efflorescence of attention to this through the great journalistic work by folks like Norm Levy and other folks who are writing about this and really digging into the details and trying to expose what needs to be exposed and also highlight what good work is being done. This is a problem that really excites and draws the attention and it raises the ire of most everybody, right? Like left, right, religious, non-religious. I haven't found a single person who you approach this problem, you broach this problem with, and who says, "Who cares?" Like everyone cares, right? Like, and most people will think that, especially private nonprofit hospitals, shouldn't be, burdening their patients with unpayable debts and pursuing them to the ends of the earth. These sorts of problems really do cut across political lines in a way that I think we definitely need right now. And so I do think that in the next few years, you're going to see changes in state law, you're going to see changes in federal law, you're going to see more and more private efforts to ameliorate this problem. It's just a question of whether it's all going to add up to kind of more than the sum of its parts.
Yeah.
We've seen attention to this in the past, and it hasn't lasted. So I do hope that this one will last.
Okay, thank you so much. You've been eye-opening and interesting, and we feel the passion that you do about this subject. So thank you so much.